This content is not designed for use as a medical reference to diagnose, treat, or prevent medical illnesses or trauma. If you have questions about the diagnosis, treatment, or prevention of a medical condition or illness, please consult your personal physician.
Hi everyone! In our next two lectures, we're going to talk in detail about stroke, which is the leading cause of death in the United States and a major cause of serious disability in adults. It affects nearly 800,000 Americans a year, with about 600,000 of these cases being a person's first stroke. About 25% of people who recover from their first stroke will have another one within 5 years, and about 3% will have another one within 30 days of their first stroke. Today's lecture is going to focus on general information about stroke, while the next lecture will primarily focus on risk factors and clinical conditions like spatial neglect that can arise from a stroke. A more technical term for stroke is cerebrovascular accident, or CVA. This term describes a heterogeneous group of vascular disorders that result in brain injury. A stroke always occurs in the brain, and it is the most common type of cerebrovascular disease, meaning a disease that affects the brain's blood vessels and circulation of blood in the brain. The label CVA or stroke is commonly assigned to clinical syndromes that are caused either by blockages in blood supply or by bleeding in the brain. There are multiple kinds of stroke, and to understand the differences between them, we need to first understand how the blood supply to the brain works. Our brain needs a constant supply of blood, which provides it with the oxygen and nutrients it needs in order to function. Different arteries supply blood to specific areas of the brain. At the base of your brain, you have something called the circle of Willis. It's basically a circle formed by the carotid arteries, which ascend up from the neck, and the vertebrobasilar arteries. The carotid arteries split into the external and internal carotid arteries. The external carotid artery supplies blood to the face and scalp, while the internal carotid supplies blood to most of the anterior regions of the cerebrum. The vertebrobasilar arteries supply blood to the posterior 2/5 of the cerebrum, part of the cerebellum, and the brainstem. Other major arteries arise from the circle of Willis and travel to all parts of the brain. These include the anterior, middle, and posterior cerebral arteries and the lenticulostriate arteries. The anterior arteries supply blood to the frontal lobes. The middle cerebral arteries supply blood to a portion of the frontal lobes and the lateral surface of the temporal and parietal lobes. The posterior cerebral arteries supply blood to the temporal and occipital lobes. And finally, the lenticulostriate arteries, which are small, deep penetrating arteries that branch off from the middle cerebral arteries, supply blood to the basal ganglia. Strokes that occur in these small vessels, the penetrating branches of the circle of Willis, or the vertebrobasilar arteries, are referred to as lacunar strokes and are usually due to high blood pressure. A lacunar stroke occurs when one of these arteries is blocked or bursts, causing bleeding in or around the brain. In a blockage, the circulating blood does not reach its destination, thereby depriving the brain of much-needed oxygen and nutrients. The cells in the deprived part of the brain then die. In a brain bleed, the bleed itself causes brain cells to die. In both cases, some brain cells die quickly, but many linger in a compromised or weakened state for a longer period of time. So the damage that results from a stroke is typically not immediately evident. It takes time to see the full effects of a person's deficits. Even though lacunar strokes are associated with a blockage or a bleed, they are placed under the most common category of stroke, known as ischemic strokes, which account for 87% of all strokes. In an ischemic stroke, an artery in the brain gets blocked, which is similar to what happens in a heart attack. This blockage prevents oxygen from reaching millions of neurons and other brain cells. Ischemic strokes stem from 3 different conditions: embolism, thrombosis, and stenosis. In an embolism, a blood clot or plaque fragment forms, typically in the heart or larger arteries leading to the brain, and then it breaks loose, making its way up toward the brain, where it gets stuck in a smaller artery, causing a blockage that results in a stroke. With a thrombosis, a blood clot forms inside the artery in the brain and blocks it, causing a stroke. So the clot itself originates within the brain rather than traveling from some other location in the body. And with stenosis, an artery in the brain or neck narrows, making it easier for a blockage to form. The most common cause of stenosis is atherosclerosis, which is when plaque deposits build up inside arteries, causing artery walls to thicken, harden, and lose elasticity. Stenosis is the most common cause of stroke in people with high blood pressure or hypertension. Common symptoms of an ischemic stroke include numbness, weakness or paralysis of the face, arm or leg, and usually on one side of the body, loss of vision in one or both eyes or double vision, trouble speaking or understanding others, loss of balance or coordination, and severe headache with no known cause. A transient ischemic attack, or TIA, is when an artery in the brain gets blocked for a short time, causing blood flow to slow down or stop. When a TIA occurs, either the artery soon becomes unblocked or a new path opens up that returns blood flow to normal. Symptoms usually last for a short period, fading away less than 20 minutes later and disappearing completely within an hour. About 1/3 of people who have a TIA go on to have a stroke in the future, usually within 1 year of the TIA. So having a TIA is a serious warning that you might be at risk for a stroke. So lacunar and ischemic strokes, as well as transient ischemic attacks, all involve some type of blockage. We also have the kind of strokes that involve bleeding, which we call hemorrhagic strokes. Here, blood vessels in the brain burst and blood spills into or around the brain. The most common types of hemorrhagic strokes include intracerebral hemorrhage and subarachnoid hemorrhage ones. In an intracerebral hemorrhage, a burst blood vessel bleeds into brain tissue. This bleeding kills brain cells and causes the affected area of the brain to stop working correctly. The most common cause of an intracerebral hemorrhage is high blood pressure. Common symptoms of an intracerebral hemorrhage include numbness or weakness of the face, arm, or leg, usually on one side of the body, temporary loss of vision, trouble speaking or understanding others, headache, nausea, or vomiting, lethargy or confusion, loss of consciousness, and seizures. In a subarachnoid hemorrhage, a blood vessel bursts near the surface of the brain and blood leaks into the space between the brain and the skull, which is known as the subarachnoid space. The blood puts pressure on the underlying brain tissue and causes blood vessels to spasm. This kind of hemorrhage is caused by an aneurysm. An aneurysm is simply a weak spot on the wall of an artery that bulges out into a thin bubble. As it gets bigger, the wall may weaken and burst. Think of an aneurysm as filling a balloon with air. If you overfill it, it will pop. If the aneurysm bursts, blood can leak inside or around the brain. Common symptoms of a subarachnoid hemorrhage include a stiff neck and a severe headache that has a split-second onset. Some individuals also experience an immediate loss of consciousness. It is imperative that anyone exhibiting these symptoms go to an emergency room. Time is brain. The quicker the person can be seen, the likelier it is that valuable brain cells and function can be saved. Just to recap, we have two primary categories of strokes: those that involve some type of blockage in the brain and those that involve bleeding in the brain. Lacunar strokes fit into either category and are typically caused by high blood pressure. Blockage strokes include ischemic ones caused by an embolism, thrombosis, or stenosis, and transient ischemic attacks. High blood pressure and atherosclerosis contribute to the occurrence of these strokes. Bleeding strokes include hemorrhagic ones, such as intracerebral or subarachnoid hemorrhage strokes, which are typically caused by high blood pressure or aneurysms. Once they are stabilized in the hospital, a person's symptoms will depend on the type, severity, and location of the stroke. Disabilities range from mild to severe and can be either temporary or permanent. Following stabilization, physical symptoms from various types of strokes can include fatigue, seizures, bladder and bowel issues, weakness or paralysis in parts of the body, pain, uncomfortable numbness or strange sensations, spasticity, so stiffness and tightness in muscles, problems with vision, and sleep issues. Mood symptoms can include anxiety, depression, which is seen in 33 to 67% of stroke survivors, and the pseudo-bulbar effect, also known as emotional lability or reflexive crying. Most often, affected individuals cry easily. Some may also laugh uncontrollably or have sudden mood changes. Communication symptoms can include Broca's or expressive aphasia, meaning someone knows what they want but has trouble saying it. Wernicke's or receptive aphasia, or trouble stringing words together so they make sense, and commands. People with Wernicke's or receptive aphasia may also not understand what people are saying. Affected individuals may also have dysarthria, which affects the ability to control muscles in the face, tongue, and mouth. So the person typically speaks slowly. And apraxia, which affects the ability to speak, read, and write. Cognitive symptoms may include problems with memory, awareness, planning, organizing ideas, and making decisions. Individuals may appear forgetful, careless, annoyed, and confused. In fact, they may even be unaware of the physical, mood, communication, and cognitive symptoms that resulted from their stroke. Symptoms also tend to vary depending on whether the stroke occurred on the left or the right side of the brain. Individuals who have strokes on the left side tend to have speech and language problems, show the inability to read, write, and learn new information, and have an impaired ability to do math or to organize, reason, and analyze information. Individuals who have strokes on the right side of the brain tend to exhibit problems with depth perception and directions, have trouble being creative, such as by painting a picture or even appreciating art, fail to recognize emotion in others' voices, and have spatial neglect. The most common means by which to diagnose a stroke include CT scans, MRI, catheter-based angiography, and ultrasound. A CT scan is used to rule out bleeding. If there's bleeding in the brain, then certain types of treatments cannot be given because they might make the bleeding significantly worse. A CT with an injection of contrast, called a CTA, can show the large blood vessels in the brain and is used to identify any blockages or bleeding that might be present. This type of scan can also be useful for identifying damaged but still viable brain tissue. A special type of MRI, called a diffusion-weighted imaging test, or DWI, can aid in diagnosing ischemic strokes. It can also identify small areas of dead brain tissue caused by the lack of blood supply. The MRI is more helpful than the CT scan when it comes to diagnosing ischemic strokes, especially smaller ones and TIAs. Catheter-based angiography is used to identify blockages in the arteries. A catheter is inserted into the artery supplying the brain and a dye injected to reveal the site of the blockage in an ischemic stroke or to detect stenosis or aneurysms. Finally, an ultrasound can image atherosclerosis in a carotid artery, and a Doppler ultrasound can measure blood velocity in large blood vessels. These diagnostic tools help to confirm whether a person is experiencing a stroke and where and what type of stroke it is. As I mentioned earlier, time is brain. Emergency medical care must be given immediately to minimize the extent of injury. Treatment needs to be given to prevent a second or recurrent stroke, and rehabilitation is needed to improve disabilities that may result from the stroke. For ischemic strokes, one time-sensitive treatment is called tissue plasminogen activator, or TPA. The aim of this treatment is to dissolve, remove, or shatter a blood clot that is causing the stroke. This type of treatment can only be used with an ischemic stroke, and it must be administered within a 4.5-hour window following the event. Research shows that individuals who received this treatment were 30% likelier to have minimal disability or even none at all 3 months after treatment. The most common medications given to ischemic stroke patients include thrombolytics to break up and dissolve clots and blood-thinning drugs like antiplatelets and anticoagulants. Antiplatelets prevent clotting by decreasing the activity of platelets, which are blood cells that promote healing by enabling the blood to clot. The most widely used drug in this category is aspirin. Anticoagulants reduce the clotting property of blood. Examples include warfarin and heparin. Some newer drugs, called direct thrombin inhibitors, are used in place of warfarin because they don't require frequent blood testing or dietary modifications. Examples include abixapan, edoxapan, and rivaroxaban. In some cases, surgeons might recommend placing a catheter into the blocked brain artery and actually removing the blockage. Of course, this procedure has its own risks and would not be recommended for all patients. For a hemorrhagic stroke, it's important to find the source of the bleed and to control it. Remember that this type of stroke is caused by aneurysms. There are 2 common treatments for aneurysms, depending on whether it is ruptured or unruptured. One treatment is called clipping. In this operation, the neurosurgeon makes a small hole in the skull and places a clip on the aneurysm neck, or the opening that connects the parent artery to the aneurysm body. This controls bleeding in a ruptured aneurysm and prevents the bursting of an aneurysm in an unruptured one. Clipping tends to be a permanent treatment. Another treatment technique is endovascular coiling or stenting. Here, the surgeon inserts a coil or stent through an artery in the groin and threads it through the vessel to the side of the aneurysm. This triggers clotting and an immune response from the body. In turn, this response strengthens artery walls, shrinks the aneurysm, and reduces the risk of rupture. There is also a newer endovascular technique known as a woven endobridge device. This is a small ball of mesh that is inserted into the aneurysm and acts as a plug. This device works well for aneurysms that have a wide neck. If an unruptured aneurysm is detected, surgeons will evaluate its potential to rupture, as well as other factors, such as whether the individual has had a prior bleed or a family history of aneurysm bleeds. They will then either follow the individual over time to assess whether the aneurysm is increasing in size, or they will recommend using clipping or endovascular techniques to treat the aneurysm. Besides drugs and surgical treatments for the different types of stroke, various forms of rehabilitation are used to help patients move on with their lives. Rehabilitation should be started as soon as possible. The most common forms of rehabilitation include physical therapy, occupational therapy, speech therapy, and vocational therapy. It really depends on the patient's needs. Neuroplasticity plays a major role in recovery. Research suggests that it takes 3 months after a stroke for neuroplasticity to return to a more normal state. After that 3-month period, improvements may come at a slower pace. At the beginning of this course, I talked about the time my mom had a stroke. She actually had an ischemic stroke that occurred in her middle cerebral artery right before it branches off near the sylvian or lateral fissure on the right side of her brain. So a large area of her brain was deprived of oxygen. She wasn't the mom I knew right after she had her stroke, and she became less and less like my mom as the days passed and more brain cells died. The day my mom had her stroke, she had gone to the doctor for a routine checkup. They took her blood pressure and a blood sample and sent her on her way. My mom had diabetes, high cholesterol, and high blood pressure, and was on medications to control all 3 conditions. Later in the day, my mom was at home on the first floor working on a puzzle, while my dad was on the computer upstairs. My mom saw a piece of lint on the living room carpet and bent over to pick it up. And that's when it happened. She collapsed on the floor and couldn't get back up. After a few minutes, my dad came downstairs and sat down at the kitchen table to work on the puzzle, but failed to notice my mom passed out on the living room floor. He soon realized this and rushed over to her side. She had trouble communicating and was in and out of consciousness. She couldn't move the left side of her body. My dad called 911, and she was taken by ambulance to the hospital. Right after my mom had her stroke, she had paralysis in her left arm and leg, pain in the paralyzed leg, fatigue, and spatial neglect. She also just seemed different than the mom I knew when it came to her communication and cognitive skills, although at the time, I didn't know whether these changes were temporary or more permanent. She still enjoyed watching the Food Network on TV, and she seemed alert. But very slowly over time, I started to notice more and more personality and cognitive changes. I'll never forget the day that my sister and I were visiting with Mom in the hospital when a nurse came in to tell her she would have Sexy Sean for physical therapy that day. My sister and I looked at each other. Sexy Sean? I turned to the nurse and asked, Why do the patients call him Sexy Sean? Oh, the patients don't call him that. Just your mother, she said. I thought I was going to die laughing. My mom was a very conservative woman. I don't think I've ever heard her even use the word sexy before. Of course, since she had a stroke, I thought to myself, okay, disinhibition, frontal lobe deficits. Similar incidents later on confirmed to me that she'd had frontal lobe damage, including childlike behaviors and a tendency to perseverate. One thing she perseverated on was getting Tylenol. After her hospital stay, my mom was transferred to a skilled nursing facility to continue her rehabilitation therapy. When I'd go to visit her, she always wanted me to go to the nurse's station and find out when she could get her next dose of Tylenol. She asked me to do this over and over and over again, often immediately after I had already done it. She focused on this entirely. It was her number one thought throughout the day. Everything revolved around the Tylenol. I'm not sure how much the Tylenol really even helped her leg pain, but she was determined to make sure she received every single dose of it. Sadly, my mom eventually lost interest in everything she used to enjoy. She no longer wanted to watch TV, do puzzles, read, go outside for strolls, or engage in any type of activity. She just sat in bed all day, sometimes sleeping, sometimes calling for nurses about her Tylenol. My mom was also unaware that she was different than she was before the stroke. My dad didn't seem to notice that anything was different either. But I think he was just hoping she would go back to being the woman he married 65 years ago. He wanted to bring her back home to live and was determined to take care of her. There's no way he could have done that, though, as she was too impaired and could not even walk. A year after the stroke, my mom contracted double pneumonia. Given the paralysis on the left side of her body, she had trouble getting the mucus out of her left lung. She died shortly thereafter at the age of 85. Strokes are pretty serious events. My dad actually had one too. He was experiencing TIAs, and when he was being evaluated at the hospital, he had a stroke. Luckily, he was at the hospital when he had it, and they treated him very quickly. He went through rehabilitation for a few weeks and thankfully made a full recovery. Prior to having his stroke, his doctors started treating him for high blood pressure. They tried a number of different medications because many of the meds they tried were giving him unwanted side effects like itchy rashes. So he got fed up and stopped taking the meds. Don't do that, ever. By golly, my dad stayed on those meds after that stroke. Okay, we went over a lot of information today. In our next lecture, we will examine risk factors related to strokes and a small handful of clinical conditions that can arise from a stroke. See you then.